So my name is Tina. I'm one of the cardiology residents here at St. Michael's Hospital. I'll be talking about hypertrophic cardiomyopathy, review of the ASE recommendations, and also just overall arching review of the role of echo in diagnosis, management of the disease. I have no conflicts of interest. And the learning objectives for us is first to review the pathophysiology of HCM. We're going to go through the definition of HCM, the prevalence, diagnostic criteria. We're going to discuss the various phenotypes of hypertrophic cardiomyopathy, recognize the patterns using echo, go through the differential diagnosis of SAM or systolic anterior motion of the mitral valve, look at the left ventricular outflow tract obstruction and how to avoid common false positives. We're also going to review the hemodynamics and the role of the mitral valve apparatus in the diagnosis and management of HCM. We'll go through the systolic and diastolic function and review the provocation strategies to bring out obstruction, recognize SAM and the MR mechanisms. We're also going to, through all of this, review some cases on LVH, LVOT gradient, and various phenotypes. And at the end, just to bring it all together and wrap it up, we'll review the management of HCM, the role of echo for ongoing monitoring of it, medical and surgical therapies that are available. So the overall goal of this talk is going to be to develop an approach for echo evaluation of HCM and understand its role in diagnosis, disease monitoring, and modification. So just like anything else in medicine, with this specific condition, we always have to start with the patient and not the image. HCM is characterized as unexplained LV hypertrophy. It's a complex phenotypic and genotypic expression of multiple genes that are involved, and it's actually one very common inherited disease. I personally was quite surprised that its prevalence is 1 in every 1 in 200 individuals. So overall, as you can appreciate on the figure on the right side, there are 15 to 20 million individuals affected worldwide by hypertrophic cardiomyopathy, and out of these, only 10 to 20% are diagnosed clinically. So when we see patients with unexplained LV hypertrophy, it's really important to screen them for HCM. And things that we're going to be looking for, especially in our younger individuals with LV hypertrophy, is any unexplained dyspnea or exercise intolerance, exertional chest pain, history of syncope, palpitations, ventricular arrhythmias, family history of HCM or sudden cardiac death, or ECG patterns such as deep T-wave inversions that are very typical of HCM. So what is then exactly hypertrophic cardiomyopathy? Because we said it's an unexplained LV hypertrophy, but not every LV hypertrophy is HCM. According to CCS guidelines, HCM is defined as maximum left ventricular wall thickness that's more than 15 millimeters at end diastole. But if you have someone with family history of HCM or gene positive HCM, for whatever reason they've had genetic testing done, if their wall thickness at end diastole is more than 13 millimeters, they would also qualify for this definition. And again, remember that the measurements is just the beginning of the diagnosis, not the end. So we'll go through all the other factors that we have to look for. And as you may appreciate, to call LV hypertrophy HCM, we need to rule out other causes of left ventricular hypertrophy. And these are just some of the examples that we're going to review next. So again, any wall thickness in the left ventricle has its own differential. Hypertension can be one of the most common causes of LV hypertrophy. It usually results in more concentric basal septal wall thickening. There is always a clinical history. Patients may be older age. You need years of hypertension, unmanaged hypertension in order to develop this type of hypertrophy. So clinical history becomes very important. Amyloidosis is the other condition that we don't want to miss. So here we can have concentric thickening of the left ventricle, usually leads to small cavities. You can see thickening of the valves and the atria, which makes it more specific to amyloidosis. And as you know, there are specific strain patterns on echo, like the cherry on top, that are very specific to amyloidosis. Athlete's heart, again, clinical history, is this someone who's a marathon runner, Olympic athlete? Do they also have larger cavity sizes in addition to their hypertrophy? And usually in these individuals, the athletes, you won't also see SAM and LVOT obstruction. And finally, coming to our hypertrophic cardiomyopathy, compared to the other conditions and on the differential here, it usually leads to asymmetric hypertrophy. You're going to have SAM, LVOT obstruction present either at rest or on provocation. And it can have characteristic patterns that we are going to be talking about. Before getting more into the echo images, I thought that it would be interesting to spend some more time just talking about the genetic inheritance of hypertrophic cardiomyopathy. 60% of individuals with HCM are gene positive. And it is important to screen for these individuals because, as you can see on the figure on the right, it helps with the risk stratifications of our HCM patients. Those with the pathogenic gene, even in the absence of LVOT obstruction on their echo, could be higher risk for developing ventricular arrhythmias, heart failure, and sudden cardiac death. So that's why we need to pay more attention to the genetics of HCM, even if the patient is diagnosed on imaging alone. And another thing about HCM that we want to make sure we don't miss is that, as I mentioned, there are 15 to 20 million individuals worldwide with HCM. And out of those, 30 to 40% present after experiencing ventricular arrhythmias, atrial fibrillation, symptoms of heart failure, exertional symptoms, and some unfortunately present first time after having sudden cardiac arrest. So it is important to remember that, and that this is one of the most common causes of sudden cardiac death in young individuals in North America, which again makes our job at really paying attention and diagnosing these patients and using imaging for the diagnosis process so much meaningful. And out of the rest of the HCM patients, actually, they are usually picked up in clinics. So these are patients who would have had ECG findings of HCM, murmur on physical exam, or have had family history and screening. So the Yamaguchi pattern for my co-residents in cardiology, so that's a classic pattern of apical HCM, which is you will see the large QRS complexes in the lateral leads with sharp T-wave inversion. So this could be, this is a classic ECG pattern for apical hypertrophy HCM. And in these individuals, once they're identified, it's also important to have a good understanding of what are some of the red flags for sudden cardiac death in HCM population, which here I have it summarized as wall thickness of more than 30 millimeters, EF of less than 50%, and presence of apical aneurysm. So according to one study, presence of apical aneurysm actually has 5 to 15% increase in the risk of sudden cardiac death. So again, why we should pay a lot of attention and get really good images, echo images, and good analysis of the HCM in this population. Here's a table on the left from the American Society of Echocardiography guidelines that recommends multimodality approach with echo and MRI. As you can see, they're actually mostly echo recommendations for identifying high-risk features and risk stratifying our patients for sudden cardiac death. Using this data on the right side, the American and the European Society have actually now introduced specific calculators for assessing for sudden cardiac death risk in this population. And when you put in that information of both the clinical and imaging-based information, they give you the recommendation whether the patient needs an ICD or not. And what's also interesting is that even though we're talking about those at risk with LVH more than 30 millimeters, this is a study that was published in New England Journal of Medicine in 2000 that showed the risk of sudden cardiac death. It's not 0 to 100 at that 30 millimeters. It's actually more of a progression of the LV wall thickness increases your risk of sudden cardiac death. So keeping that cutoff in mind is important, but knowing that the larger the wall thickness, the higher the risk of sudden cardiac death. Okay, so here that was some of the background that I wanted to cover. So now let's talk about different phenotypes of HCM, and I'll be going through each phenotype. This is just a big summary image, and then after that, we're going to go through the corresponding echo images in the future slides. So first, and the most common morphology on the left side here, it's our sigmoidal HCM. So it's the pattern of basal septal hypertrophy of the sigmoid septum. It is the most common presentation of HCM. 40 to 50% of patients have this pattern of HCM. It is also most likely associated with dynamic obstruction. The genetics of these patients are actually less associated with the pathologic variant. In comparison, our second phenotype here is the reverse curve HCM. 30 to 40% of HCM patients have this phenotype. And actually, this is very important to identify because patients with reverse curve HCM are the ones that usually are most likely to have the positive genetic finding for pathologic arrhythmogenic events, and they overall have a worse clinical outcome. And next here, we have our apical HCM, which is a pattern that over time leads to the thinning of the apex and formation of aneurysm. And as I mentioned, again, identifying aneurysm in HCM is very important because it characterizes them as higher risk individuals. And the fourth phenotypic type of HCM, which is more on the rare side also, is our neutral HCM. That can be very difficult to identify. It is concentric hypertrophy pattern. The fact that it's more of a diffuse LV hypertrophy could make it more challenging to identify. So aside from these four phenotypes, there is an additional morphology that's recognized by the American Society of Echocardiography, and that one is the mid-ventricular obstruction that is also leads to our apical aneurysm formation and puts patients in higher risk of developing bad cardiovascular outcomes over time. So on the left side, and so you can actually appreciate some very interesting Doppler findings in this group. So in this image on the left side, you can see that there's mid-LV obstruction and a large aneurysm at the apex. Systole will lead to the obstruction of the hypertrophic anterolateral pap muscle area. And you can appreciate that in the Doppler waveforms, you can see a mid-systolic drop. So I just found that that's very interesting that you can actually see that drop because of the presence of that mid-ventricular hypertrophy and the aneurysm. And on the right, you would have your apical mid-hypertrophic cardiomyopathy without the aneurysm. And as you can see, you don't see that drop in the Doppler wave compared to the one with the aneurysm in this phenotype. So now let's move into more of the looking at the echo images of these different phenotypes. So this is, again, the sigmoidal septum. That is the most common type of our hypertrophic cardiomyopathy. And at a first glance, it could look like this is your hypertensive LVH with your proximal sigmoid hypertrophy. However, the sigmoid septum here exceeds our 15 millimeter criteria for HCM. And also in some cases, you could have mitral valve SAM. Next here is our reverse curve HCM. Again, this is the one associated with the pathogenic gene types and high risk of sudden cardiac death. Here you would have the marked thickening of the mid-ventricular septum. And one thing that's very interesting is that, as you can appreciate here, you actually have distortion of the LV cavity in your parasternal long axis view. And you can appreciate how thick the septum is. In many cases, again, you can have LVOT obstruction and SAM in this phenotype. Third, our apical HCM. Here, the apical HCM is really known as your the spade shape cavity, and that's because when you use contrast, you can really appreciate how the cavity looks like a spade. This is when your LV wall progressively thickens, and contrast in this case can be very helpful in identifying your apical HCM with better endocardial definition. And what happens is that monitoring these patients longitudinally is very important, because the same patient who had this apical HCM 2 years later, with the use of contrast for better endocardial definition, you can appreciate that now they have also developed an aneurysm. And we know that, again, they might be at higher risk of developing thrombus and ventricular arrhythmias. Okay. And here we have our neutral HCM. Again, it's a more of a rare phenotype of hypertrophic cardiomyopathy. It can be more subtle because the hypertrophy is more diffuse. And the difference between this and the reverse curve HCM is that you don't have the distortion of the LV cavity that you had with a reverse curve. And then here, as you can see here, it's a more just linear hypertrophy rather than just the septum. Okay, and here as well, we have the morphology of the mid-ventricular HCM, our last phenotype. Again, you can really appreciate the flow acceleration over here, that there is obstruction here in the middle of the LV. In these cases, as with the apical HCM cases, your contrast can be very helpful in identifying this morphology and ruling out presence of an aneurysm. So, as you may have inferred by now, echo is the first-line imaging modality for identification of HCM. And now that we're gonna have echo answer the following questions for us, for our HCM patients. What is our wall thickness? What's the pattern of HCM? What is our EF? Do we see any specific strain pattern for our systolic function? Echo is also really helpful in HCM for left LA size and filling pressure assessments, presence of MR, SAM, LVOT gradient, and if there are any valvular abnormalities like aortic stenosis, how would that play a role? One thing that we don't want to miss, again, using echo for these patients is any apical disease, any mid-ventricular obstruction, apical aneurysm, and how they change and their physiology actually changes and hemodynamics changes when we use Valsalva and try to provoke the gradient. And what's important is also to know is that a good echo should explain patient's physiology. We don't want to, in the report, just write that this is consistent with HCM. We want to report the gradient, what happens to the patient when we provoke the gradient, and really help the clinician in terms of the management of the patients from a medical clinic in the clinical setting. So now that we've discussed how echo helps us diagnose HCM and appreciate the clinical significance of it, let's discuss how it will guide us in monitoring disease progression. And we'll start with assessing the systolic function of HCM. So as hypertrophic cardiomyopathy progresses, there's progressive worsening of the myocardial fibrosis. And as a result of that, good LV function assessment can be very important. It's also important for our risk stratification in this group because, as mentioned, drop in LVEF also puts patients at a higher risk of sudden cardiac death in this group. And so using strain or global longitudinal strain in HCM is becoming more and more popular and helpful. Echo features of HCM that makes it different than a normal LV is that we can actually have drop in our GLS. And not only that, but also if we, interestingly, if we use GLS's polar map, we can also identify specific phenotypes of HCM, which I found very interesting. So here, the figure on the right side, panel A is showing a parasternal long axis view of a patient with basal hypertrophy and septal HCM. And you can see that in the polar map, the strain polar map, it's showing reduction of the strain at the septum. And the other picture that I have here is an apical two-chamber view of a patient with apical HCM. And as you can see, that corresponds with the strain at the apex. So strain assessment in HCM will not only help us with assessing the systolic function in this cohort, but also it helps us with the pattern recognition and risk stratification of the patients. Diastolic function also is very important, a thorough diastolic assessment in this cohort, because early signs of decompensation in HCM could show up as diastolic dysfunction. So here, if we have a look at the images on the left, if we start from the top left panel, we are showing the mitral inflow velocity that's measured at the mitral leaflet tips. You can appreciate that an elevated E to A ratio, which we know is a method of showing restricted filling pattern, can be associated with elevated LVEDP in HCM patients. The top right panel is showing our peak tricuspid regurgitation velocity, and the bottom two panel are showing our Doppler velocities measured at the septum and the lateral aspect of the mitral annulus from a symptomatic patient with HOCM and dilated left atrium. So this table right here, this graph here, it's from the American Society of Echo guidelines for HCM. And it's a way of assessing diastolic dysfunction in this population. So if you have left atrium size of more than 34, you have an E to E prime ratio of more than 14, and a peak TR velocity of more than 2.8, you will have a good way of figuring out if there is left atrial pressure overload. If you meet 3 of these criteria or 2 of these criteria, then you can defer that in this patient with HCM, you have elevated diastolic, elevated end diastolic pressures. However, if you only have 1, then the LA pressure is normal. If you're anywhere in the middle, then it's really indeterminate, the diastolic function in this group. Another very interesting marker is also to assess elevated LVEDP in this cohort is manifested in atrial reversal velocity in our pulmonary vein Dopplers. So if you look at the image on the right, so that's our pulmonary vein flow. We have this AR, which essentially is showing the atrial reversal into the pulmonary vein. The higher the difference in flow duration between our atrial regurgitation symptom in the pulmonary vein, so the AR, and the mitral inflow wave, the higher the left atrial pressure and LVEDP, and the worse the diastolic function in our HCM patients. And that duration, you can calculate it, so AR minus A duration. If it's more than 30 milliseconds, it indicates diastolic dysfunction in HCM. As you can appreciate, we don't always get good pulmonary vein Dopplers, but when we do in HCM patients, it can be very helpful. Oh, sorry. Okay. You may also notice that from a diastolic function perspective, we are not talking about grading diastolic function in this population, but whether or not there's abnormality in relaxation or not. So that's one thing important to keep in mind, especially with the new diastolic guidelines. So aside from going back to assessing for HCM function using echo, aside from assessment of systolic and diastolic function, we also need to do a thorough assessment of the LVOT obstruction in these patients. So on the left side, you can appreciate that in the 2DM mode of parasternal long axis view, if we look at the mitral valve leaflet, after the QRS or right after our systole, we can see here and appreciate really on the 2D that there is the systolic anterior motion of the mitral valve. We can also, in our echo images in the three apical three-chamber views, we can appreciate the physical movement of the anterior mitral leaflet towards the LVOT, which also corresponds with the flow acceleration in our outflow track. So what makes our LVOT obstruction happen is a combination of two mechanisms in this case. It's the LVOT narrowing from the septal hypertrophy and also the intrinsic mitral valve abnormalities that predispose mitral valve in the case of HCM to SAM. And that was really actually interesting for me to read on because the fact that the mitral valve itself there are anomalies in it in patients with HCM, aside from the physical and hemodynamic effects of the septum itself. So aside from the physiology and the LVOT affecting the mitral valve, these intrinsic anatomic abnormalities that are present in the mitral valve apparatus makes it prone to developing SAM. So in HCM, our papillary muscles can be bifid, so they could have two heads, and they can be anteriorly displaced towards the ventricular septum, that's shown here in this image. And they can have some abnormal insertions also into the mitral valve. And when the pap muscle is anteriorly displaced, it brings the entire mitral apparatus close to the septum, obstructing the outflow tract. On the right, this is a central image from a JACC paper that they did a thorough review of the shape of the mitral valve and the anomalies of mitral valve in obstructive HCM. So if we look at it, the figure, so in panel A here, we can see that there's elongation of the anterior leaflet of the mitral valve in some HCM cases. B shows elongation of the posterior leaflet. C shows elongation of both leaflets. And in D, we have thickened anteriorly displaced papillary muscle. E, we can have anomalous anterolateral pap muscle head that inserts directly into the anterior mitral leaflet. And in F, you can have abnormal cords that are under tension. And because of that tension, they can lead to LVOT obstruction and predisposing the mitral valve into developing SAM. So overall, the combination of the anomalies in both the leaflet, pap muscle will predispose the mitral apparatus into developing SAM in the presence of LVOT gradient. And as many of you are familiar with, this LVOT gradient can be exaggerated during provocation and Valsalva. And the higher the gradient, the more obstruction we are going to see. We talked about the fact that the cutoff for hemodynamically significant gradient is 30 millimeters, and over 50, that's where therapies are indicated. That's why measurement of these flows and the velocity Dopplers are very important. And why does maneuver like Valsalva increase the gradient? It's because of the fact that with Valsalva, we're going to have increased intrathoracic pressure, and that will then reduce our preload into the left ventricle, and that it brings the thickened LV wall and the mitral apparatus closer together, worsening the obstruction, leads to much larger gradients on echo, and also louder murmur clinically. So that's what we're essentially looking at. But like anything else in medicine, we have, again, differential diagnosis. Not every LVOT obstruction with SAM is HCM. So that's also really important to keep in mind. We could be scanning patients in ICU who are in septic shock, hypovolemic shock, and they could they could have LVOT obstruction and SAM doesn't mean that they have HCM. We could have patients with Takotsubo with very hyperdynamic basal LV function that would have this, and again, doesn't mean they have HCM. So, or even patients on inotropes could have obstruction without the presence of HCM. So, very important to keep this in mind. As I mentioned, it's diagnosing HCM is a whole complicated, many factors that go into it. Another aspect of the echo findings of HCM is the presence of the mitral regurgitation. LVOT obstruction is often concurrent with mitral regurgitation, and that is because the anterior leaflet moves towards the LV outflow tract, creates a coaptation gap between the mitral leaflets that could lead to very noticeable mitral regurgitation. And because of that mechanism, most often your mitral regurgitation flow is actually posteriorly directed. It is very important when we are looking at the Doppler signals for the continuous wave Doppler as to how we are drawing that. Because as you can appreciate, for instance, in a case like this, we have the MR jet going this way and the LVOT gradient this way. So it's easy to get contamination of your MR signal with your LVOT Doppler signal. One way that we can actually think of the MR signal and the LVOT signal to be a bit different is that MR happens right after systole, but your LVOT obstruction gradient usually starts appearing in mid to late systole. And here at the bottom is an example of a contamination of your, as you can see, that this is the dagger shape, this is your LVOT gradient here, but there is a contamination of this more symmetric mitral regurgitation flow. So it's very important to keep that in mind. With regards to our LVOT obstruction, a sign that during our residency training, we were taught actually by our interventionalist staff is the Brockenborough-Braunwald marrow sign, which is very specific to HCM. And it looks at it's a hemodynamic sign, essentially, that evaluates HCM with LVOT obstruction. It is as a result of a decrease in pulse pressure and increase in peak systolic gradient after a PVC occurring that leads to more forceful contraction in the first sinus beat after the PVC. So from the gradient perspective in the cath lab, we can see it here. But what is I found it very interesting is that we can actually see this exact sign in echo when we have a PVC, if we are lucky to capture that. So as you can see, when we have a PVC, which is a premature ventricular contraction, then there is a compensatory pause. It allows for a longer ventricular filling time, which will then lead to increased contractility in the subsequent sinus beat. And that will then increase your aortic pressure. But when you have HCM, it paradoxically worsens your LVOT obstruction, and that's why you would see larger gradients. I found that this is very neat, and if you can see it in HCM, again, another sign of our LVOT obstruction. Another sign is our aortic valve fluttering, that we don't necessarily see it always, but if we see it's, I found the hemodynamics of it also very interesting. So when you have LVOT obstruction, you can have this aortic valve fluttering, which is also known as mid-systolic partial closure. It's a classic echo sign of LVOT. It happens because you have high velocity blood accelerating through a very narrow outflow tract. It creates a localized drop in the pressure, which is called the Venturi effect. And it causes the aortic cusps to briefly flutter and prematurely close in the middle of systole when they're not supposed to. So that could be another sign you could see in our HCM patients. So We know that the obstruction in these patients is associated with worse symptoms in these individuals in the clinical setting. So as a result of that, it is important for us to assess the level of obstruction on provocation so that we have a better assessment of how these patients do when you're at home, out and about, exercising, in order to help also guide their management and therapies. So here's the algorithm from the American Society of Echo that says that if you have LVOT gradient at rest or on provocation, and if it is less than 50, you can still proceed with doing an exercise stress echo. And depending on whether at rest or whether on the stress, you would develop gradients more than 50, you should be initiated on HCM therapies that we're going to discuss. But other means of coming up with this provocation is, aside from exercise, is Valsalva, which we do in the echo labs, squat to stand. In the cath labs, they also do the butamine, isoprotanol, and PVC, which again shows whether you would have increase of your gradient. So altogether, these signs and plus the patient clinical symptoms will all help us diagnose and manage the symptoms of these patients. So now let's talk about the therapies that are available. We're doing all of these measurements, these numbers, where do they go? So if we have a patient with symptomatic HCM, one of the first things we need to do is to identify the mechanism of their symptoms. Are they symptomatic because there's obstruction, or they're symptomatic in the absence of obstruction? If they're symptomatic, they're short of breath, they have low exercise tolerance, in the absence of obstruction, we maybe need to optimize their medical therapy with beta blockers, calcium channel blockers, or they might be having symptoms of heart failure and they need diuretics. And if on these optimized medications, again, in the absence of obstruction, they're symptomatic, maybe they're heading towards the route of advanced heart failure management. If they have obstruction, however, and that's why they're symptomatic, then we need to, again, optimize their medical therapy, volume depletion, make sure if they're volume deplete, we need to make sure that they're euvolemic. If someone has put them on vasodilators, we need to make sure that's stopped, optimize their use of beta blocker and calcium channel blockers. However, despite all of these, if they're still symptomatic and their gradients are elevated, then that's when we start talking about their septal reduction therapy options available. So with regards to septal therapy reduction, the indication for initiation of these therapies is gradient of more than 50 at rest or when patients provoked. We always start with medical therapy for these patients using cardiac myosin inhibitors, which is mavacamten. Many studies have now shown improved quality of life, symptoms, and even improve in imaging markers, echo markers in these patients when they're on mavacamten. But how does mavacamten work? As I mentioned, mavacamten is a cardiac myosin inhibitor. So as you may recall from the cardiac physiology classes, normal cardiac contractility requires actin and myosin in order to form cross bridges in the sarcomere, and that will lead into the contractility. In HCM patients, there is one theory that there are too many of these actin and myosin heads, cross bridges that are formed that causes the hypercontractility and the thickening of the LV, and leads to also impaired relaxation. So what mavacamten does is that it reduces the ATP hydrolysis and decreases the number of this actin-myosin cross-bridge formation at the molecular level. So it leads to reduction of the contractility and less symptoms in these patients. However, as you can imagine, when you reduce the actin-myosin cross-bridge formation, you also put the patient at risk of dropping their LV function and contractility globally. So because of that, I think this table, which is from the CCS guideline recommendations, you can really appreciate that how echo plays such a critical role, not just in diagnosis, but also ongoing management of these patients longitudinally. They need a regimented follow-up plan after initiation of mavacamten at baseline, week 4, week 8, week 12. Once they're stabilized on it, ongoing every 3 months assessment, looking for symptoms, looking for any drop in their systolic function, just to see if there's an opportunity to start them also on GDMT and manage them from that perspective. And if you ever have any interruptions in the mavacamten, you really just go back from the beginning and you start from the baseline again. So I actually saw a patient on mavacamten in clinic, which is really interesting because, and I pulled out their echo. So this is their echo before initiation of mavacamten and after. So before start therapy, their intraventricular septum was around 18 millimeters. They were quite symptomatic. 2 years post-therapy, the septum is now 14 millimeters. So you can see it on echo that there's also a reduction in the obstruction in this patient and clinically asymptomatic. And according to the CCS guideline, there are still some patients who would not respond to mavacamten. And what would you do after that? So according to guidelines, that's when you, if they're symptomatic despite the medical therapy with mavacamten, you move on to the surgical options that are available. And the surgical options that are available are our septal ablation therapy and the surgical myomectomy. In order to differentiate which patient is more appropriate, obviously it involves a discussion with the patient, their preferences, but in general, those with more advanced age and comorbidities and with more focal septal hypertrophy, they're better suited for our alcohol septal ablation, and those who are younger, less comorbidity, and they have more of a diffuse septal hypertrophy, they could benefit better more from the myomectomy. So with that, I would like to then summarize this talk. Thank you so much for all of you for listening. So just to summarize, we can appreciate how HCM is such a complex disease with many morphologies and presentations. As always, we will have to start with the patient, not the image, integrate their symptoms, history, family history, ECG, and other image findings. HCM is more than just LV wall thickness. There is a differential that we reviewed for any LV hypertrophy. We talked about the different mimics of HCM, different phenotypes of HCM, and other signals to look that would lean you towards the fact that the patient is having a specific phenotype of HCM, like the GLS, looking at the apical disease. We also discussed the diastolic function and how important this is for risk stratification of the patient, and the markers that, as the ASE guideline, are recommended to look at, such as your LAVI, the E to E prime ratio, TR velocity, and ARA difference. And we also talked about the importance of interrogating the obstruction, recognizing how MR could contaminate our signals, and how to cause provocation of the obstruction, and really appreciating how echo plays a longitudinal role in the management of our HCM patients, not just the initial diagnosis. And with that, thank you so much. Just want to leave with this last message that a good HCM echo doesn't just diagnose, but also helps understand the physiology, identify high-risk features, and guide therapy. Thank you.